Hi, this is Dr. Jeff here at Smart Plastic Surgery. We're here in Miami. And today we're going to talk about a complex breast case. So my background, I'm fellowship trained as a board certified plastic surgeon. I've been trained in craniofacial surgery and hand and upper extremity surgery. So I've done a lot of reconstructive surgery over the years. This is my 25th year in practice now. So I enjoy doing complex cases that require some thought. This is one example of a complicated breast case. This nice woman underwent a mastopexy with implant, or mastopexy augmentation, a number of years ago in Venezuela, where she's from. And my understanding is that what happened shortly afterwards is that she had a dehiscence, or a separation of the incisions. You can see how these have subsequently healed. There was an infection that occurred following that, and she was wearing a garment, possibly a band, potentially up above, which we often use for, say, augmentation procedures, to basically guide the implants into their pockets postoperatively. I don't really use it often with lift procedures or breast reduction procedures, but nonetheless, from her description, this is what she had following surgery. And it appears that not only was that placed improperly, but it was probably placed a bit too tightly, because there was a lot of skin loss in these areas, in the periareolar regions, both above the nipple areolar complex and below that. And you could see that on both sides equally. So that almost simulated a burn. Okay, and if you take a closer look, you can see really like reepithelialization, where you have pigmentation that occurs from the follicles themselves, forming small spots of pigmentation. And that's typically what we see following burns. I've treated many, many burns over the years, and this is what we see. So she's had a very complicated course where she's basically sustained an infectious process, a wound, a complex wound separation process, as well as a burn, all together in one postoperative course. So her goals were to basically redo the lift, of course. She wanted to go to a smaller implant. These were actually 460 cc's initially, and she wanted to reduce that by about 100 cc's. So we went to 340 cc's silicone implants placed below the muscle. This is what she looked like on the operating table at the time of the procedure, and you could really, this is a little bit of a different angle, really looking from below the breast, and you could really appreciate the extensiveness of these burns, of these, scars that occur on both breasts. And you saw them before above the nipple areolar complex, and now you can really appreciate the inferior aspects of it's almost as if there was this skin loss, subsequent secondary healing by contraction and granulation, and then subsequently the resulting scar that formed. So what I did was remove those implants, went to a smaller size implant, which would give me a little bit more malleability of the tissue, so I can manipulate this and modify this. I have more tissue to work with, in essence, by using a little bit of a smaller implant. But more importantly, the patient wanted to be a bit smaller, all right, than she started. So we reduced her by about 100 cc's. Redid the periareolar anchor type of modification of the lift with implant exchange, and this is how she appeared in the operating room immediately afterwards. So all of that scar tissue has been removed, both above the nipple, vertically, and horizontally beneath. The steri-strips are not hiding the scar tissue there. They've healed nicely. They've been approximated nicely with complete removal of that. These smaller implants have been placed below the muscle.
Question: how did you remove all the tissue and then create like that shape again? Because it's easier when you just do a lift.
Right. So part of the procedure, of course, involved removing all of this badly scarred tissue, potentially burned tissue, okay? So that includes, so my incision typically would go around the nipple areolar complex, vertically straight down, and horizontally under the breast. Basically an anchor type of incision. In her case, that incision had to be much wider, right, to first off include the scar above the nipple areolar complex, but also to include all of this tissue on each side. And then if you take a look from below, all of this tissue. So my incision, of course, was in the inframammary fold below the breast, but then came up, so it was much wider than a normal inverted T or anchor type of incision, and that encompassed all of this scar tissue, so all of it can be removed. Leaving any of it behind would remain kind of a traumatic reminder for this patient of the previous situation. So the goal here is to remove all of that, okay? What helped me do that was going to a smaller size implant. So that was part of the plan. She wanted to be a bit smaller, so that worked out very well. So removing the implant put less tension on the incision. Going to a smaller implant allowed me to remove this tissue. So there are different, components to the surgical planning of a case like this. That allowed me to remove all of this scar tissue all the way across. So that's gone. At this point, the implant is removed, the original one is removed, the new implant is placed below the muscle, and then the flaps are then approximated, so they're touching, and then closed and sutured. And then that's how we go from there to this here. So you can see all of the scar tissue has been removed, and now we're just left with these very fine scars, something that she was hoping that we could restore for her. And here she is down the road. We don't see it from below. She's still very fresh post-op. In fact, the strips are still in place. Actually, it's just a couple of weeks after the procedure, but she's done very well. So that's really the thought process that goes into these different reconstructive procedures. And here she is at a photo, about about a month or so following the procedure that she's sent back to us, and she's very pleased. So we do have follow-up from this patient. So hopefully this case will inspire patients to send questions, send photos, anything I could help with from a reconstructive perspective. But we do these types of procedures not just for the breast, but also for, the belly, other types of reconstructive issues that arise, whether it's from burns, infection, whatever the case might be, or congenital changes. It turns out, God doesn't do symmetry, so that's one of the things that keeps me busy. And we deal with asymmetries, all the time, whether it's the breast or whether it's other parts of the body, or the face. So feel free to send us questions, send photos, and I'd be happy to respond to those and give you my opinion one-on-one. So again, this is Dr. Jeff here at Smart Plastic Surgery, and I look forward to hearing from you soon.